Hello, student. Now we're going to talk about the hematologic system, oncologic conditions, and anemia. Next slide. All right, so what is hematology? Hematology is the study of the blood and blood-forming tissues. Right? The key component of hematology includes the blood-forming tissues that include the bone marrow, the spleen, and the lymphatic system. Next slide. So what does the blood do? What does it do? Well, very important roles that it participate in. One is transportation. 2 is regulation. And 3 is protection. How does it transport? Well, it uses the oxygen. It transports oxygen, nutrients, hormones, and waste product. It regulates the fluid and electrolyte and acid-base balance. And it protects us by coagulation and by fighting infection. Next slide. So the component of blood, a majority of it is plasma, 55%. And then you have the blood cells, which are 45%. And there's 3 types of blood cells. Erythrocytes, which are the red cells. Leukocytes, which are the white cells. And thrombocytes, which are the platelets. Next slide. So, erythrocytes, the red cells. Erythrocytes are red, so red cells, right? So they are red cells production. They're stimulated by hypoxia and controlled by erythropoietin in the kidney, right? In the kidney. Hemolysis are destructions of the red cell, right? And releases bilirubin into the bloodstream. Hemolysis is seen, with certain diseases, because the normal lifespan of red cells is 120 days. And when some of these cells, when they are injured, it's less than that 120 days. Next slide. The leukocytes, the white cells, there are 5 types of them. You have basophils, eosinophils, neutrophils, monocytes, and lymphocytes. Each of them have its own role that helps to fight for us, to maintain the immune system. Next slide. So the leukocyte, like I said, are the different types. So neutrophils, what is the cell function that it does? Takes place in the the inflammatory process. Parasite infection. For eosinophils, basophil, again, that is seen usually with an inflammatory process and hemolytic or allergic responses. The lymphocyte, immune response, and cellular immune response with the monocytes. Next slide. So thrombocytes, they are helpful to make sure that we form blood clot, and it is involved in homeostasis. When you cut yourself, the thrombocytes are the ones who go to the site and form a plug to stop us from bleeding. So clearly, when we have low level of platelets, the patient will be at risk for bleeding. Next slide. So homeostasis. So the normal clotting mechanism, right? So the goal is to minimize blood loss whenever we are injured, right? So you have the vascular response, which forms vasoconstrictions. So dilation allows things to flow. Constriction stops something from flowing. And then the platelets is activated and form the clumps that I was talking about. And then the plasma clotting factors come in place. So you have factor 1 through factor 8, and using the intrinsic and extrinsic pathways. Next slide. So anticoagulant, right? Anticoagulant elements that will interfere with blood clotting. There's counter mechanism to blood clotting, which keeps the blood liquid and able to flow. Anticoagulant, right? So there are drugs that we use to prevent that from happening, to prevent the blood from clotting, right? Especially with someone who is at risk for thrombos, like atrial fibrillation. Next slide. What are the structure of the hematologic system? We said bone marrow, the liver, and the lymph system. So now let's talk about each one of those. Next slide. The bone marrow, soft substance in core of bone, inside the core of the bone, right? The blood cells production takes place here, right? And here all the cells are being made. So red cells, white cells, and plate cells. So if something happens with the bone marrow, then you will see a problem with all of these, cells that we've just described. Next slide. The liver receives 24% of the cardiac output. That is about 1,500 mLs of blood each minute. It has many functions, and some of those functions includes synthesis of plasma protein, including clotting factors, and albumin. So it also clears damage and non-functioning RBCs and erythrocytes from the circulation. So it's very, very important. Next slide. The spleen, which is located in the upper left quadrant of the abdomen, right? So it too has function in hematologic area. So it produces the fetal red cells. It filters and reuses certain cells. It has lymphocytes and monocytes, and also store 30% of platelets. Next slide. Are there some effect on the hematologic system when it comes to aging? The answer is yes. The complete blood count is the test that you do to see your any issues with the blood cells, right? Complete blood count. So when you look for the older person, when you do a CBC, complete blood count, there will be lower hemoglobin and have lower response to immune because they have less WBC. And platelets, generally there's no change, thank God, all right? The clotting factors, the PTT, it's slow or lower. Next slide. So now, in terms of assessment of the hematologic system, every system we start off with collection of data. Assessment is the first step of the nursing process. And we're going to collect always subjective information, so it's least invasive to most invasive, because before you start touching somebody, talk to them first. And you go gather information. You're going to gather information about their past health history. You want to know, do they have sickle cell? Do they have anemia? You want to find out about their medication that they're currently taking. You want to find out about any surgeries or any other treatment that they've completed in the past. Next slide. You want to talk about the functional health patterns. What is their perception of health? Their nutritional status, right? Elimination, do they have any problems with that? Their activity, are they able to tolerate exercise or they're not? What about their rest and sleep pattern? Any cognitive perceptual problem, self-perception, the concept, any relationship, the role in relationship and support, any sexuality issue or coping or stress intolerance or value or belief. Next slide. And then you go into objective data. So you want to do a physical assessment, starting off with the techniques. So you have inspection, auscultation, palpation, and percussion, right? So inspect the skin, for the color, for any impairment, right? For warmth, right? For coolness. inspect it for redness, for lesions. Inspect the eye. Is there jaundice? Inspect the mouth for sores. The tongue, is it smooth? Palpate the lymph nodes and see if they enlarge. Listen to the heart and lung, because anemia can cause heart failure if it's not treated. The abdomen, inspect it for size, for distension. Auscultate it for sound. Palpate for organomegaly. The nervous system, alert and orient. Musculoskeletal. So you go through each of the nursing, the physical assessment of each system. Next slide. So a complete blood count is going to look at the different types of cells. So a complete blood count, you have CBC. So normal WBC is 4,000 to 11,000, right? So it associated with infection, inflammatory, right? So leukopenia is less WBC. Neutropenia is less neutrophils. So someone who's neutropenic is at risk for infection, right? They both can put them at risk for infection. So your patient that is taking chemotherapy, they are neutropenic. And then your red cells tells you the normal level. Hematocrit is the percentage of whole blood that is composed of red blood cells. The hematocrit is measured in both the number of the red cells and the size of the red cells. So some of them are macrocytic anemia. We're going to talk about that. Okay? Next slide. And in the WBC, also looking at the platelet count. Normal platelets 150 over 400, right? Thrombocytopenia is low platelet count. So someone who is low, they're at risk for bleeding. And they can bleed spontaneously if the count is below 2,000, 20,000. Pancytopenia is decreased in the number of not just the red cells, the platelets, also the WBC. So they have more than one issue here. And usually if there's the problems originating in the bone marrow, you may see all of these. Next slide. Radiologic studies, so you can do for hematology, you can do a CT scan, MRI of the lymph tissue, biopsy to confirm cancer, bone marrow examination, lymph node biopsy to confirm cancer. Next slide. So this slide is just showing you again the common diagnostic test for hematologic and lymphatic system, and it tells you the normal values that you should expect. All right, and then some of the nursing implications. So someone who's getting a red blood cell done, what are some of the nursing implication? Well, do you need to fast for the red cell? No fasting or special client preparation is necessary. So it's important, right? But we have to explain why it's done. All right, the results may be affected by what? Your hydration status. Remember we say when you have too much, you have hemodilation. When you have, too little, it look like it's more, but it's not. Reticular count. Again, no fasting is needed. Okay, we have to explain. Hemoglobin, no fasting is needed. Hematocrit, right? No fasting is needed either. Most of the tests are no fasting needed. Next slide. WBC. All right, no food or fluid restriction is required. Right, neutrophil. So usually they say WBC with differential. Right. So they want to see specifically not just the blood count. They want to see the differential is the different component of the WBC. So they want to see the neutrophils, the eosinophils, the basophil, the lymphocyte, the monocyte. So when they say differential WBC count, they're looking at each of the component that makes up the WBC. And then of course the platelet We've already talked about that, and we say that the client again does not need any preparation because we're just going through the vein. So for bleeding time test, normal is like 3 to 5 minutes. So it's used to screen for disorders that are caused by platelet, dysfunction. So, but if a patient has been taking aspirin or other anticoagulant drugs, that time is going to be prolonged. So it looks like it's abnormal, but it's because we know why. So you must ask questions about the kind of drugs that they're taking already. Next slide. And the PT, prothrombin time, it's going to evaluate the extrinsic clotting pathway. So this is the test that we want to look at if somebody is on Coumadin therapy. The other name for Coumadin is warfarin. INR, right? That's the international normalizing ratio. And again, it's also used to evaluate the Coumadin therapy. INR provides a more standardized measure of Coumadin. So they use more INR than PT. And then you have PTT, that is also used to evaluate the clotting factor, the pathways of it, but it's more sensitive than the PTT. All right, there's no restriction of fluid, and you use that to assess heparin. And then the Coombs test. The Coombs test it helps us to diagnose hemolytic anemias and evaluate transfusion reaction. All right, so it expect results are no detected antibodies. So what we do is for this test, even though there's no food or fluid restriction, which is good, most of these, but you want to find out about previous transfusion or transfusion reaction. Hemoglobin electrophoresis, right? Hemoglobin electrophoresis. So there's different aspect of it. You see, when you do the electrophoresis, you're looking at the different types of hemoglobin. So hemoglobin A is 95 to 98%. Hemoglobin A2 is 1.5 to 4. Hemoglobin F is less than 2%. That's hemoglobin F is fetal hemoglobin. This is really important when it comes to sickle cell, right? It is performed to detect abnormal forms of hemoglobin associated with genetic hemolytic anemia. So sickle cell anemia, thalassemia, right? So hemoglobin A. So hemoglobin, the hemoglobin is sickled in sickle cell. Again, there's no fluid restriction. The sickle dex is screening. The hemoglobin electrophoresis is really going to tell us. It's going to show the different causes, the different reason why they're sickling. So it's going to differentiate, someone who is the carrier of sickle cell versus someone who has the disease. So sickle dex is going to screen it, but the electrophoresis is going to really tell you, yep, this patient has sickle cell disease. All right. So positive results definitely for each one of those genetic counseling is important. Next slide. Iron is also another hemolytic test that we do, right? Total iron binding capacity and iron. So pretty much, what we try to do is, because, the iron, the body stores and measure to evaluate, so iron, we will evaluate if there's iron deficiency. The things you need to know about the iron is that antibiotic, estrogen, testosterone, and oral contraceptive, aspirin and ethanol would affect the result. Right? Ferritin is another test that we use, to measure the amount of iron stored in the body tissue. No food, and then results in the women are affected by the age and, of course, of the use of oral contraceptive. For transferrin, it's another test, that we use to assess the transport of iron into the bone marrow. We have to avoid iron supplements 12 hours before testing. And then D-dimer is a fragment produced when fibrinolysis occur, and is used primarily to diagnose DIC, disseminated transvascular coagulation. So literally this person is just bleeding pretty much everywhere. There's no fluid restriction, and then we have to monitor manifestations such as unexplained bleeding and monitor the signs, vital signs. Next slide. Schilling's test is another test, right? Primarily used to diagnose pernicious anemia. These are very important things. Pernicious anemia. This time test evaluates the body's ability to absorb vitamin B12 from the GI tract, right? So this is vitamin B12 testing. An oral dose of radioactive targeted B12 and an intramuscular vitamin B12 injection are administered, and then they're followed by collection of a 24-hour urine specimen, right? So pretty much here you want to verify that there's an informed consent. The patient has to withhold food and fluids for 8 to 12 hours before the test. They have to avoid taking any B supplements for 3 days before the test. They may eat and drink after the B12 injection is given, and observe for manifestation of anaphylaxis for at least 1 hour after the administration of the radioactive B12. And then we collect the urine for 24 hours using rubber gloves to handle the urine because it's radioactive, radiation, right? Next slide. So now, what is anemia? Anemia is a reduction in the number of RBC, the quality of hemoglobin, or the volume of RBC. You're going to see that in the different diseases. Because the main function of RBC is oxygenation, so when someone doesn't have anemia, it results in a degree of hypoxia, right? Because it carries the oxygen. Hemoglobin, oxygen. It's really important. Next slide. So, what are some prevalent conditions that can cause anemia? Well, blood loss, decreased production of erythrocytes, or increased destruction of erythrocytes. So, you're losing blood, you're not making enough of it, or there's an increased destruction of it, like hemolysis. Next slide. So, what are some of the manifestations? Remember, RBCs is red, so they will be pale, pallor, fatigue, dyspnea, right? Palpitation, tachycardia, headache, dizziness, restlessness, slowing of thought, paresthesia. Next slide. So what are some of the nursing management? Well, direct management towards decreasing the cause. What is causing it? Is it because of blood loss? So let's stop it. All right, replacing the blood loss as needed to sustain oxygenation, promote optimal activity and promote and protect from injury, reduce activities and stimuli that cause tachycardia and increase cardiac output, provide nutritional support, so things that are high in iron, administer any prescribed nutritional supplement, patient and family education. Next slide. Administer oxygen as prescribed. So this is one who is anemic or suffered blood loss. Administer blood product as prescribed. Administer erythropoietin as prescribed. Allow for rest between periods of activity. Elevate the patient's head on the pillows during the episode of shortness of breath. Provide extra blanket if the patient feels cool. Teach the patient and family about the pathophysiology and how to manage the symptoms of anemia. Next slide. So, this is anemia that is caused by decreased erythrocyte production, right? Anemia caused by decreased production of erythrocytes. So, iron deficiency anemia, thalassemia, and megaloblastic anemia. Let's talk about each one of them. Next slide. Iron deficiency anemia. And how does it happen? Usually inadequate dietary intake. So, it's found about 30% of the world's population. Or someone who has some malabsorption issues in the duodenum and the GI, maybe due to GI surgery. Someone who has blood loss. 2 mLs of blood contain 1 gram of iron. GI or GU losses or hemolysis. breaking down of red cells. Next slide. So what are the clinical manifestations? The most common is pallor, because remember, red is red. Second most is inflammation of the lung. It's like glossitis, cheilitis, inflammation and fissures around the lips. So remember when we're inspecting that oral mucosa, they're very sensitive to cold. There's weakness and there's fatigue. What are the diagnostic studies? CBC, iron deficiency studies, iron levels, so total iron binding capacity, serum ferritin, remember all those different things we were looking at, endoscopy and colonoscopy. If you're suggesting, the suggestion is, GI base. Next slide. Treatment of an underlying disease and problem, and we're going to replace the iron. We're going to diet that are high in iron. Iron therapy, so oral iron, phosphate. So we need to make sure it's usually absorbed better with acidic environment, right? So you're not going to give milk with that. Orange juice will work best. Parenteral iron, IM or IV. So with an IM, you have to monitor for anaphylaxis, right? The Z-track method, where it's locked in place, prevents staining. Oral is usually less desirable. If it's liquid, it may stain the teeth, causes constipation, it may tar the stool. So you have to teach them about that. Next slide. Assess cardiovascular and respiratory system. Monitor for the vital signs, recognize any signs of bleeding. So stool, because they could be losing the blood because of bleeding, right? So the stool, make sure that it is not occult, it's not bright red. The urine, monitor the emesis. Teach them the food that are high in iron, like organ meats. Provide rest. Supplemental iron. Do the blood work to see the level. Emphasize compliance. And iron therapy is usually 2 to 3 months after the hemoglobin levels return to normal. Next slide. Thalassemia is an autosomal recessive genetic disorder, autosomal recessive, right? And it's found in the Mediterranean ethnic groups, and it's usually asymptomatic, major retardation and life-threatening. You see splenomegaly, hepatomegaly. And so by law, when all the kids are born, they are screened for this hemolytic condition. This is one of the ones we're screened for. We're screened for sickle cell. We're screened for PKU. We're screened for hypothyroidism. Right? Next slide. So there's no specific drug or diet that is effective in treating thalassemia. So there's thalassemia minor, so the body just adapts to the decrease of hemoglobin. Thalassemia major, what has to happen is blood transfusion, that is given to remove the excess iron from the body. Next slide. Megablastic anemia is characterized, mega means large, right? Large RBCs which are fragile and easily destroyed. All right? The common forms of megablastic anemia it's folic acid is one of them, and vitamin B12. Cobalamin, vitamin B12 deficiency. Next slide. So vitamin B12 deficiency, formerly known as pernicious anemia, right? It is important water-based, water-soluble vitamin, and it's required intrinsic factor for absorption. So anything that causes a decrease in intrinsic factor would probably create a problem for absorption of vitamin B12. So gastric mucosa, not secreting intrinsic factor, the GI surgery, someone who has lost their intrinsic factor from a bypass, gastric bypass, long-term use of H2 histamine receptor blockers, right? Because it can cause atrophy or loss of the gastric mucosa. people that have nutritional deficiency, and those who have inherited defect of cobalamin utilization. Next slide. So what are the clinical manifestations? General symptoms of anemia. There's the sore throat, sore tongue, anorexia, weakness, paresthesia of the feet and hands, and there is alteration in thought process, which can lead to confusion and dementia. Next slide. So diagnostic tests, if you look at the cell under the microscope, they're large in appearance, abnormal shape. The structure contributes to the the erythrocyte destruction. Remember, we talked about the Schillen's test. It's used for the patient with vitamin B12 deficiency. Next slide. So we have to administer cobalamin. So once it's deficient, they have to take it. So we have to increase it daily. They have to be replaced, or monthly, depending on the form, how it's presented. Next slide. So it's important to identify early on individuals that are also at risk for vitamin B12 deficiencies are individuals who are vegetarian. So we have to assess the vegetarian. That's why they have to do replacement of vitamin B12. All right. So we have to make sure that they're compliant with it. Assess for injury, because diminished sensation to heat and pain. Ongoing evaluation of GI neurologic status, because they can also evaluate the patient for gastrocarcinoma for frequency, because the deficiency may lead to that. Next slide. Folic acid deficiency is the other one. Folic acid deficiency may also cause megaloblastic anemia. Folic acid is required for red cell formation and maturation. Right? It's also needed to help with neurotube, to prevent neurotube defect. So when we get into maternity, that's something that we have to talk about, the nervous system. So what are the causes? Poor diet intake, malabsorption syndromes, diet that inhibit absorption, alcohol abuse, and hemodialysis. Next slide. So clinical manifestation is similar to that of vitamin B12, insidious onset and progress slowly, absence of neurological problems, is treated by replacing the folate. And we have to encourage patients to eat food that has large amount of folic acid, so leafy green vegetables, liver, mushrooms, oatmeal, peanut butter, and red beans. Next slide. So anemia of chronic disease. So diseases that can cause anemia. So what you see is underproduction of red cells, shortening of the RBC survival rate. Second most common cause of anemia after iron deficiency anemia. Generally develops after 1 to 2 months of sustained disease. So people that have impaired renal function, chronic and inflammatory infections, or malignant disease, chronic liver disease, folic acid deficiency, splenomegaly, and hepatitis. Next slide. Aplastic anemia is caused by pancytopenia. Remember, we talked about all the different cells that are affected. So red cells, white cells, and platelet cells are all low. Hypocellular bone marrow, so it's usually the bone marrow, right, that is affected here. So what are the causes? Can be congenital, or it could be acquired. Acquired from exposure to radiation, chemical agents, viral and bacterial infection. Next slide. So low incidence, affecting 4 out of every 1 million persons. Manageable with erythropoietin or blood transfusion, can be critical condition, so because it can lead to hemorrhage and sepsis. Next slide. So clinical manifestation, gradual development, symptoms caused by suppression of any or all bone marrow elements. General manifestation of anemia is fatigue, dyspnea, pale skin, frequent or prolonged infection, unexplained or easy bruising, nosebleed and bleeding, prolonged bleeding, cuts. So remember, aplastic, everything, the bone marrow is all the different cells. So when you don't have enough red cells, the signs and symptoms you see. When you don't have enough platelet, the signs and symptoms you see. When you don't have enough white cell, the signs and symptoms you see. Next slide. So diagnosis. So blood test, CBC, blood marrow, biopsy is how you confirm it. Next slide. Treatment, we find the underlying cause, blood transfusion, antibiotic, immunosuppressive, steroids, big deal right there. Bone marrow stimulant, Neupogen, Epogen, bone marrow transplant if we have to get to that point. Next slide. Prevent complication from infection and hemorrhage, and prognosis is usually poor if it's untreated. It's 75% fatal. Next slide. Anemia that is caused by blood loss, either acute or chronic blood loss. Next slide. So acute blood loss results from sudden hemorrhaging, so trauma, surgery, vascular disruption, or the collaborated care is replacing the blood volume, identify where the hemorrhage is, and stop the blood loss from happening. So this is an acute loss. Chronic blood loss, similar to iron deficiency anemia, because it's chronic over time. So GI bleeding, hemorrhoids, menstrual loss. So diagnostic studies is to identify the source and stop it. Collaborating care is supplemental iron deficiency, like someone who has fibroids in every menstrual cycle, they're bleeding profusely. That could be chronic if it continues. Next slide. These slides are talking now about anemia that is caused by increase in erythrocyte destruction. Right? Remember we talked about hemolytic anemia. So there's destruction. So there's different types of anemia that occurs because of the red cells being destroyed. The most frequent one is sickle cell. You have acquired hemolytic anemia, hemochromatosis, and polycythemia. Next slide. So hemolytic anemia, destruction or hemolysis of red cells at a rate that exceeds the production. Third leading cause of anemia, intrinsic hemolytic anemia, so abnormal hemoglobin, enzyme deficiency, or RBC membrane abnormality. Extrinsic hemolytic anemia, the red cells are normal, but is damaged by external factors such as the liver, spleen, toxins, or mechanical injuries. Next slide. So the sequence of events. Right? Next slide. So acquired hemolytic anemia can be caused by medication or an infection. It's acquired. Manifestations are signs and symptoms of anemia, as we've talked about already. Complication is accumulation of hemoglobin molecules that can obstruct the renal tubules, leading to tubular necrosis, causing kidney problems. Treatment is to eliminate what is causing it. Next slide. What are some of the potential nursing diagnoses for this client with anemia? Activity intolerance related to weakness, malaise, imbalanced nutrition less than body requirement related to poor intake, anorexia, and the evidence is albumin level is low, iron levels are low, ineffective therapeutic management regimen related to lack of knowledge about nutrition and medication, as evidenced by collaborated problems, hypoxemia, related to decreased hemoglobin. Next slide. Hemochromatosis, so this is iron that is a lot. So iron overload disease, too much iron. So overabsorption and storage of iron causing damage, especially to the liver, the heart, and the pancreas. So if you have too much iron, you got to replace it. So phlebotomy is a treatment for it. Next slide. Thrombocytopenia is the condition in which there is a net increase in the total number of red cells. Too much red cells. So overproduction of the red cells for many reasons, such as, the bone marrow decide to proliferate, do more, produce more, or maybe reaction to chronically low oxygen level or malignancy. Next slide. Complications. So you see increase in viscosity of the blood. So you see hemorrhaging, you see thrombosis, phlebotomy, myelosuppressive agents can help. Next slide. Thrombocytopenia is the cells of decreased platelets disease. Platelets, right? So the platelet count is less than 150. So what caused? Maybe low production of it or increased breakdown of it. So you see signs and symptoms that shows you that platelet is low, which means they're going to bleed. So bruising, nosebleeds, petechiae. Next slide. So there's different types of it. There's immune thrombocytopenic purpura, so which is abnormal destruction of the circulating cells. It's autoimmune, or destroying host spleen by the macrophage, or thrombotic thrombocytopenia purpura. Next slide. Or you can have heparin-induced thrombocytopenia, and heparin-induced, so associated with administration of heparin. So it develops when the body develops an antibody or allergen to heparin, therefore causing thrombosis. So clinical manifestation is thrombocytopenia, impossible thrombosis after heparin therapy. Next slide. So diagnostic tests, you do platelet count, PT, PTT. Treatment is finding the cause, steroids, plasma, pheresis, splenectomy, and transfusion of platelets. All right, so that ends the thrombocytopenia. Now I'm going to talk a little bit about sickle cell anemia. Sickle cell anemia is a anemia that is inherited form of something called classified under hemolytic anemia. When it's more prevalent in African American, it can be seen in Middle Eastern and Mediterranean area. What happens is there's the gene. It's autosomal recessive gene, meaning that to pass on the disease to a child, the parent have to have either the trait, so dad has the trait, mom has the trait, or dad has the trait, mom has the disease, or both mom and dad have the disease to pass on the disease. So for each pregnancy, there's a percentage of chance to get the trait. For example, if dad has the trait and mom do not have the trait, baby can never have the disease. Baby can have something called a trait too. So every pregnancy, there's 50% for dad to pass it on, to pass the trait to her child. Remember, I said dad has the trait, mom does not have the trait. All right, so every pregnancy, there's 50% chance to pass it on, the trait. And there's 25% chance the trait will not be passed on, right, at all. I mean, there's 50% chance that it will be passed on, the trait, and 50% chance it's not going to be passed on. But if mom has the trait and dad has the trait, that formula changes, right? So again, that's with every pregnancy. So now there's a 50% chance that they're going to pass the trait, right? And then there's a 25% chance that they're going to pass the disease. And then there's a 25% chance that a kid is not going to have the disease or the trait. And hemoglobin electrophoresis is how we confirm it. Sickle dex is how we we suspect or screen for it. Like how you have HIV test, you have, ELISA, see if there's antibodies, and then Western blot confirms it. Same thing here. Because someone who has the trait has some type of sickling. So someone who has the disease definitely has some type of sickling. So the sickle cell, the sickle dex is only telling us, is there some sickling that is there? If there is, then we can confirm it now. Okay? So the issue is that the shape of the hemoglobin change. It's concave shape. It's sickle, from concave to sickle. So that's the problem. And when that shape changes, it can actually obstruct the blood, the vessels, or the kidneys. It can cause a lot of major stuff. All right? There are certain things that can cause like crisis, all right? Like extreme temperature change, tissue hypoxia. So usually the clinical manifestation, of course, pain. Pain is a big deal for these guys. Pain, there can be jaundice, from the sickling of the cells. It can cause major complication, infection, stroke, renal failure, heart failure. So in terms of the assessment and diagnostic findings, we'll do CBC, right? And of course the BBC, if there's an infection at the site, the level will be higher. The sickle dex, as I told you, that's the routine screening test that determines the presence of hemoglobin S, but it does not differentiate between the sickle cell anemia and the trait. And then the hemoglobin electrophoresis is what we use that would tell us, identify any abnormal hemoglobin types and differentiate between the sickle cell trait and the sickle cell anemia, right? The SED rate may be elevated. The erythrocyte will be very fragile. If we do ABGs, because of hypoxemia, in acidic state, you can, that causes the vasoconstriction, vaso-occlusive crisis, they usually call it. LDH may be elevated. The potassium and uric acid level may be elevated. All those can trigger vaso-occlusive crisis. So management is really continuously researched, but they talked about peripheral blood stem cell transplant may help with this. It may cure the sickle cell anemia. However, it's only available in a small subset of affected patients. Right? There's transfusion therapy. Chronic RBC's transfusion therapy may be effective in preventing, the complication that comes from sickle cell anemia. There's a lot of supportive therapy that is given that includes adequate hydration. It's really, really important during a painful sickle cell episode. Aspirin is very helpful in diminishing any mild to moderate pain. NSAIDs are useful for moderate pain in combination of other opioid analgesics. Pulmonary function test is monitored because pulmonary hypertension is usually treated and found, because that's one of their complications. Pharmacological therapy, there's hydroxyurea, that's HYDROXYUREA, has shown to be effective in increasing the fetal hemoglobin levels in patients. Fetal hemoglobin level has the sickling property. It's not the issue. Argin, ARGININE, has anti-sickling properties and enhances the availability of nitric oxide, which is the most potent vasodilator, which results in decreased pulmonary artery pressure. So in terms of nursing assessment, we want to focus on any of the factors that can cause, that caused the previous crisis, so that we can control it for next time. Pain level is big deal, so the pain level should always be monitored using a pain intensity scale. And when we are assessing the pain, we got to find out the characteristics, the quality, the frequency, and any factors that aggravate or alleviate the pain. Infection, so these guys with anemia are susceptible to infection, right? So we have to monitor for that. What are some of the nursing diagnoses for this client? Well, acute pain is a big deal, right? Acute pain related to the tissue hypoxia due to the sickling cells within the blood vessels. Risk for infection is another one. Risk for powerlessness related to the illness induced helplessness. Knowledge deficit regarding sickling cell and crisis prevention. All right. So when you're managing the pain, again, subjective, support and elevate any joints that are involved, swollen until the swelling diminishes. Teach them about relaxation techniques, breathing exercises, and distraction to cease pain. With acute episodes, implement aggressive measures to preserve function. So physical therapy, whirlpool, to prevent infection, monitor for signs and symptoms of infection, initiate prescribed antibiotics that are given, monitor for signs of dehydration, teach the client to take prescribed oral antibiotic at home, promoting coping skills, enhance the pain management to comfort, focus on the patient's strength rather than the deficit that they have, and increasing knowledge, teach them about the situation that precipitate a sickle cell crisis, such as hydration, avoiding stressful situation, keeping warm. If hydroxyurea is prescribed, for women in the childbearing age, that's an issue. So inform that the drug can cause congenital harm to the unborn child, and advise about pregnancy prevention. Monitor for complications. So some of the complications that may have will be leg ulcers, right? Prevent the leg from trauma and contamination. Prolonged erection, that could be a big deal. Teach them to empty the bladder at the onset of an attack because, distended bladder can precipitate that. Chronic pain and substance abuse problems. So emphasize the importance of complying with the prescribed treatment, promoting the trust with the patient about adequate amount of acute pain. Promote home and community-based care. So teaching about the disease, assessment, monitoring, advise healthcare providers. Evaluate the pain, making sure that the pain is maintaining its effect. Assess for any vascular problems, and document. So document the description of the pain they report, the accepted level of pain, any prior medication that was used, any signs and symptoms of infection, and their response to the interventions, the teaching and actions. All right, that ends our lecture for hematology. Thank you.